Namaste. I, JVN Sheetal Singh, Assistant Professor at Jayoti Vidyapeeth, Women's University, Jaipur, in Faculty of Pharmaceutical Science. So today we will study the second unit and our topic is drug interaction with pharmacokinetic and pharmacodynamic activities. So in the previous topic, we have completed what is pharmacokinetic. We have completed what is pharmacodynamic. The full ADME we have covered. Now let's see what is in this. So let's start from the definition. So first, what is drug? First, we will let know what is interaction. An interaction is said to occur when the effect of one drug is changed by the presence of another drug, herb, food, drink. Okay, or we can say the drug interaction is defined as pharmacological activity of one drug is altered by commencement use of another drug or by the presence of some other substances. The drug whose activity is affected by such an interaction is called as object drug. Okay, so the agent which precipitate such an interaction is referred as precipitant. So these two definition you must know. Now the type: drug-drug interaction, drug-food interaction, chemical drug interaction, drug laboratory test interaction, drug disease interaction. An interaction occurs when the pharmacokinetic or pharmacodynamic activity of a drug are changed. Now let's see the cause. So polypharmacy, multiple prescription, multiple pharmacies, generic makeup, specific population like female, elder, obsessed, malnutrition, and ill person, transplant recipient, all have different physiology. So specific illness, for example, hepatitis disease, renal dysfunction, and narrow therapeutic index of some drug like cyclosporin, digoxin, insulin, lithium, antidepressant, and warfarin. So now let's see the mechanism of drug-drug interaction. Pharmacokinetic involves the effect of a drug on another drug. Kinetic that include the absorption, distribution, metabolism, and excretion. Pharmacodynamic are related to the pharmacological activity of the interacting drug. For example, agonist, synergy, altered cellular transport effect on the receptor side. The net effect of the drug interaction is generally quantitative, increase or decreased effect, select amount, qualitative, rapid or slow effect, and precipitation of newer or increased adverse effect. Pharmacokinetic interaction. These interactions are those in which ADME property of an object drug is altered by the precipitant and hence such interaction are called as ADME interaction. The resultant effect is altered plasma concentration of the object drug. These are classified as first absorption interaction, second distribution interaction, third metabolism interaction, and fourth excretion interaction. Absorption interaction, it mainly include alteration in GI, pH, alteration in gut, motility, inhibition of GI enzyme, complexation, and absorption. Alteration of GI, microflora, and malabsorption syndrome these are mainly affect the absorption interaction. Alteration in the GI-pH. The non-ionized form of a drug is more lipid soluble and more readily absorbed from GIT than the ionized form does. Some drugs are absorbed from stomach, acidic media. So when the media become natural or alkali, this will affect the absorption of drug. For example, sulfonilamide and aspirin, when given with antacid, lead to enhanced dissolution and BA. And next example is ketoconazole or tetracycline with antacid lead to decreased dissolution and BA. Now, the alteration in the bacterial flora. Bacterial flora has marked a role in the metabolism of some drugs. Long-term antibiotic may kill normal flora and affect the drug absorption. For example, 40% or more of the administered digoxin dose is metabolized by the intestinal flora. Antimetabiotics kills large population of intestinal flora, thus decrease the digoxin concentration. And so the digoxin concentration is increases and change of the toxicity is also there. Now, let's move towards the complexation and the chelation. So in this topic, we will cover many examples and you have to write the example. For example, tetracycline or fluoroquinones like ciprofloxacin with antacid or food containing divalent ion lead to formation of poorly absorbed chelates or complex which cannot be absorbed. Now, second is cefaxin and sulfomethoxazole warfarin with cholestyramine lead to reduced absorption due to binding. So these are the some examples you have to write in your exam. Then the alteration in gut motility. Some drugs usually alter the GIT emptying time by altering the peristalsis of the gut, hence lead to deficient the absorption. For example, aspirin, levodopa, diazepam co-administered with the metoclopramide lead to rapid gastric emptying and increase the rate of absorption. Some drugs with atropine lead to delayed emptying and decrease the absorption. Now, the malabsorption syndrome. For example, vitamin A, B12, digoxin with neomycin or collagen lead to inhibition of absorption due to malabsorption. Now, we will see the interaction. So now I will share a screen for you and you can easily see that. So in this, you can see the distribution interaction of a drug. So in this, you can easily see the importance of the protein binding for the intensity and the duration of drug effect. You can see this drug, which is not bound to the plasma protein. So this drug is directly affected to the cell and give its effect. And then the remaining drug is biotransformed, and then the renal elimination of the drug is there. But in this, you can see if the drug is strongly bound to the plasma, then what happens? If that drug is strongly bound to the plasma, then it directly goes to the renal elimination and without giving its much effect. So the remaining bound drug is bound to the effector cell, but the effect is very low. And the biotransformation is also done, but it is not that much faster. And the renal elimination you can easily see through this diagram. So now the competitive displacement. It depends on the affinity of a drug to the plasma protein. The most likely bound drug is capable to display another. The free drug is increased by displacement by another drug with higher affinity. For example, phantoin is the highly bound to the plasma protein, 90%, and tolbutamide is 96%, and warfarin is 99%. Drugs that display these agents are valproic acid or phantoin toxicity and sulfonamide aspirin lead to bleeding. Now, the metabolism interaction, the effect of one drug on the metabolism of another is well documented. The liver is the major site of drug metabolism. This we have already known. But other organ can also do. For example, WBC, skin, lungs, and GIT. CRIP 450 family is the major metabolizing enzyme in phase 1. Hepatic metabolism, as we know, it is of two types, phase 1 and phase 2. Phase 1 is modification and phase 2 is conjunction. So the CRIP 450 most important isoenzyme responsible for liver metabolism. CRIP 3A4, CRIP 2D6 and CRIP 2C8 are the main enzyme proportion of where the drug distribution take place. So the enzyme induction. A drug may induce the enzyme that is responsible for metabolism of another drug or even cells. So let's see the object drug, then the precipitant drug and their influence. For example, the oral coumarin and the contraceptives and tarbutamides. They are the objective drug, and the precipitant drug is barbiturates. They mainly decrease the plasma level, leading to decrease the efficacy of object drug. Then in the another example, the object drug is here is theophylline, cyclosporin, and contraceptives, oral contraceptives mainly. But the precipitant drug here is phantoin. The main influence in this is they decrease the plasma level, leading to decrease the efficacy of object drug. Now, the third example is in the object drug, the example is oral contraceptives, coumarin and tolbutamide with rifampicin as a precipitant drug, and the influence is decrease the plasma level leading to decrease the efficacy of object drug. So the rifampicin increase metabolism of cephalosporin by inducing CRIP3A4. So the enzyme inhibition most common than the enzyme induction. This interaction decrease the drug metabolism and so increase its concentration. It seems it take 2 to 3 days. Object drug, precipitate drug, and influence drug. For example, the folic acid, if it is object drug, then the disulfiram is the precipitate drug. The influence is disulfiram-like reaction due to acetaldehyde. Coumarin, if coumarin is the objective drug, then metronidazole is a precipitant drug which increase the chance of anticoagulation. And next example is alcohol, benzodiazepine, and warfarin. If these are the objective drug and the precipitant drug is cimetidine, the influence is increase the blood level of the object drug. So this is how it works. So the basic, so from this we will understand how the drug is interact and how the enzyme inducing interaction in the drug is take place and what is the role of the enzyme and inducer in the drug interaction. So hope you will understand this. For any query you can comment below. Namaste.